Well, good morning. I would like to call order the joint subcommittee on human services. Secretary, if you could please call the roll.
Senators Canizaro, Don Darrow Loop, Stone, Titus, Wynn. Here. Assembly members Brown May, Dickman, here. Hafen, Hibbets, Howdigi, here. Monroe Moreno, here. Yeager, here. And Chair Mosca.
And I am here. Thank you so much. If you could please mark Senator Titus and Assembly members Brown May and Hafen present as they arrive. I would like to remind everyone to please silence your cell phones and electronic devices and remind you that public comment will be available at the end of the meeting. We have a few budgets that we're going to go over today, and with that, I would like to invite our presenters to the table. As you're getting ready, don't forget to state your name for the record. You can go direct to the members, and we will stop at each budget item for questions. And you may begin when you're ready.
Thank you so much, Chair Mosca. Good morning. You good? Okay. Members of the committee and Chair Mosca, my name is Cody Finney, and I serve as the administrator of the Division of Public and Behavioral Health. Today, I'm joined by our Deputy Administrator for Fiscal Services, Andrea Rivers, and our statewide coordinator for Forensic Services, Drew Cross. We do have a quite amazing team of experts with us today in case you have specific questions related to some of these issues. And we're focused today on our behavioral health budgets. All right, on slides 2 and 3, as you've seen before, we briefly highlight our mission, vision, and purpose, as well as the core values of the agency. On slide 4, we have the highlights of the operational units. Again, a very broad division with a lot of activities going on. Slide 5 is our current organizational chart. It does not reflect the changes that are proposed in this budget. And slide 6 is the pie chart that is the overall funding by source throughout the entire division, including public and behavioral health. All right, on slide 7, we get to what's a little more interesting today. This pie chart breaks out the federal and other funding for the behavioral health budgets in particular. The highlights here, we do have most of any increase we are seeking this year is in this side, and that's primarily related to forensic mental health services. This part of the division is far less likely to be dependent on federal funds than our public health budgets. And as you can see in the next slide, for forensic services, federal funds are almost non-existent. So that next slide is a table of the same breakouts of funding source by budget account for those of you who prefer a table format. All right, on slide 9, we start with the budget accounts. 3168 is the Behavioral Health Administration budget, and this budget is historically was the main administrative budget for behavioral health services. Since a number of years ago when we merged public and behavioral health, some of those activities have been merged into 3223, which I presented on at a previous hearing. And so all of our overall grant management activities and those things are now being operated out of 3223. And so those pieces really are division-wide. We do have the revenue management unit in this budget account. That is the billing for our mental health services where those are reimbursable, and the psychology internship program. All right, on slide 10, we have the only enhancement unit for 3168. This budget is removing an accounting assistant 1 from that revenue management unit that I mentioned. We had not been successful in recruiting that position, but we were successful in distributing those duties in a reasonable way, and so we can eliminate this position without undue burden to the agency. I'm going to stop there for questions regarding 3168.
Thank you so much. So for this first budget item, members, do we have any questions? I believe we have no questions on 3168, so we can keep going to the next one. Thank you.
Cody Finney, for the record. Thank you, Chair, committee members. The next two slides, I'm diverting from specific budget accounts just a bit to give a little bit of foundation for the clinical services budgets. So on slide 11, there's some basic information about the inpatient capacity that we have in the division where we are providing direct mental health services. Since the Medicaid expansion in 2014, opportunities for reimbursement for community services have expanded, and we have seen a reduction in demand for the state services, particularly in our outpatient services. So what you can see here, however, is that our inpatient services continue to operate, particularly our forensic inpatient services are operating very, very close to capacity. I do want to point out here that unlike our civil services, our forensic services operate as a statewide system. So for many, many years, we have moved patients across the state to receive forensic services, where in the civil service, those are more regional, and people stay in the community from whence they came. All right. Slide 12 illustrates the some of the pressure that we've had about getting people into those inpatient forensic services in a timely manner. This shows the fines that have been imposed from the district courts. They have at times fined us, and since September of 22, we've paid a total of $181,500 in fines. We have had some relief in recent months from those fines, and the courts have expressed their gratitude for the number of things that we're doing to try to mitigate the length of time and the number of people waiting. And we've had some significant success in reducing both of those. Those efforts included planning and requesting a new facility in Las Vegas, renovating Building 3A in Las Vegas that you've heard me speak about at a number of events, to provide another unit for forensic services, and particularly having some of our longest term, most infirm patients receive services in community nursing homes where they're better able to be served, and then we have that capacity for other patients. At this point, we're receiving signals from the courts that some of these fines may be reimposed. We were frankly so successful in the southern portion of the state, and continued to have that process I mentioned where we move patients to the northern portion of the state, that we saw some of those wait lists increase for northern and rural clients. We've since made some adjustments to that so that we can balance that a little more effectively. But when we make those adjustments, it does take some time. Okay, so that's just a little bit of the history related to some of these things we're going to talk about now. Budget account 3161 is Southern Nevada Adult Mental Health Services. This budget account includes the Deanie Townsend Hospital. I'm sorry, that is incorrect. This budget account includes the Ross and Neal Hospital. Oh, goodness. All right. This budget account includes the Ross and Neal Hospital, the Stein Hospital, and the SNAMS outpatient services. Those are both civil and forensic. So unlike in the north, where we have separate budget accounts, this budget account has both. All right. Enhancement units for budget account 3161. M201 is based on previously legislatively approved caseloads and adds some caseworkers for our justice-involved diversion program. So these are folks that are still in the civil service, not like me, the civil services, but are being diverted because they do have some justice involvement at a lower level, and we're trying to prevent them from getting into those higher level inpatient needs. All right, E250 is the staffing for that building 3A that I mentioned. This body has previously approved the emergency renovation contract that is getting that up to speed so we can use it to serve 21 forensic patients. And this would be the staffing that's necessary to then run that unit. E252 continues the successful use of community skilled nursing beds for those long-term patients that I mentioned before. All right, on slide 15, we have E254, and this decision unit anticipates the approval of the 1115 waiver that Medicaid has submitted, and that would make a portion of our civil inpatient services reimbursable. So we calculated based on the number of people that are Medicaid reimbursable in the past, how much would be reimbursable once that waiver is approved. On slide 16, in Decision Unit E268, this provides ongoing funding for the mobile crisis services provided by the North Las Vegas Fire Department. This model has shown success, and we're working with Medicaid and our partners at Behavioral Health, Wellness, and Prevention to integrate this model into the overall 988 and crisis services structure. But they've done an amazing job of setting this up in their community, so we want to make sure that that is sustainable in the long term, and this will help us keep going. E606, this decision unit was intended to eliminate 4 positions that were chronically vacant. The positions that were originally identified didn't remain vacant. We have been working like busy bees to fill positions, and we were also working like busy bees to develop the budget, and we got a little crosswise. So the slide that you have does not have no longer has the correct positions. I want to express my gratitude to my fiscal staff, my program staff, and most especially the legislative staff for working with us this week to make sure that we could find a good solution or a solution to this problem, because I was unwilling to come to you today and say that I was going to eliminate a position that had a real person in it and create real consequences for a real staff member. So we're not doing that. We identified an alternative AA position, an alternative CSA position, and rather than the auditor and the CPM, we have 2 clinical program planner positions that are all currently vacant that we are proposing for today. We have additional detail on that, should that be helpful to you. All right, on slide 17, E606 eliminates the annualization of our residential support activities. So this will mean SNAMs will have to reduce the number of people that they're providing housing assistance for, because that annualization brought us up to the level that we're currently being served. E652, this decision unit proposes the elimination of 12 senior psychiatrist positions and the replacement of that funding into Category 8 so that we can use that to hire contract staff positions. I will say that's not a one-for-one. We do have additional positions that remain available, but this would allow us to operate as we have, essentially, as long as that funding is moved into Category 8. All right, I'm going to stop there for questions on 3161.
Thank you so much, and thank you for that helpful context at the beginning as well. And with that, we do have several questions. So we will start with Chair Nguyen.
Thank you, Administrator Finney. I do have a couple of questions. I think I'm going to kind of start with some of the renovated services for the forensic building. I know that you kind of gave, sorry, look at this. I'm very short here. I'm going to move over here to the side. No, you're fine. You're fine. Oh, perfect. There we go. There we go. I put him in like a kiddie chair down there. And I've got a booster seat too, so it's like it'll all work out. Anyway, some levity to our morning. I have some questions. You had talked about the building out of these forensic beds, and I know that we have talked about building 3A ad nauseum, and I'm sure you are sick of hearing this. I also know that we've had some improvements, so I appreciate the documentation that you provided to this subcommittee regarding, at one point, I think, to get the individuals from the detention centers into these forensic beds was taking, on average, I think at one point it was 129 days. And now it sounds like as of February 12th, and hopefully this is still the case, it's about 74 days, although that is still 2 months longer than I think we are required to transport those people into other beds. It sounds like this, I guess, these 21 new forensic beds will be available come May, probably like more closer to July. Is that correct?
Cody Finney for the record. So we expect the construction to be completed about May. The staff we're requesting then would be available in July, if that's approved.
That makes sense. And I know that you are asking for 53 new positions are recommended to be funded starting on that July 1st. Obviously, with the prediction that this is going to be completed, knock on wood, May, that doesn't really give you a whole lot of time to hire 53 people, get that place staffed up and ready to accept those incoming patients. Is there any reason that all of these positions are included to start immediately and they're not staggered, or is there a plan? Is it just to like try to get everyone in there and open it up, knowing that on average you have about a 10% vacancy rate?
Thank you, Cody Finney for the record. Certainly we wouldn't be hiring those positions and putting them all in that unit. So these are the number of positions we need to run that unit. We would be hiring those positions and dispersing them, the actual people, throughout the existing units that are operating, and getting them trained up and having existing staff work in that new unit with along with new staff. We would never staff a unit with entirely new people, is what I'm trying to say. So we anticipate that we could hire very quickly and get that unit up and operating. As I had on that slide, the beds we have are very, very full.
So there is some flexibility. It's just a lot of money to hold out there for budgeting purposes when we know that, I mean, the reality is it seems like you're not going to be able to get them up and running July 1st.
Cody Finney for the record, we're going to get as close as we can with what you give us to work with.
Okay. I guess my second question is, you had indicated May, and I see Mr. Rob here, so maybe he has some updated information about the completion of that construction project. Like, how close are we on actually completing this project and these renovated beds by May? Is it May 1st? Is it May 31st? Are we realistically talking about later on in the summer?
Jack Robb for the record. Within the past 2 minutes, I did get a text back that says May 15th.
Okay. That's a very definitive date, which I appreciate. That brings me to my next question, kind of in line with this, is when we talk about that, I know at one point in late fall, we had about 149 individuals that were on the waiting list to be transferred. This is obviously not 149 beds. I know that there is, a recommended CIP project to build out a much, much larger and needed forensic hospital with hundreds of beds. How will this alleviate that wait list and our ongoing, I think it's $500 a day per person that isn't transported within 7 days? We're just paying out contempt of court fees. So how are we going to get more in alignment with that?
Cody Finney, for the record, thank you for the question. This is one piece, Building 3A is one piece in an array of things that we're doing to try to address the need for this service. But the need for this service does continue to grow. So this allows us, again, to have another 21 beds of capacity. We previously added about 30 beds of capacity and reduced that waiting list, as you said, from 129 down to 74. And the other piece of what we do is continue to manage the length of stay, the length of time that those patients are staying with us. And so by doing those two pieces together, and by trying to divert people who don't need that very high level of service into other services, we have been able to make significant progress and continue, and believe we will continue to do so. Forgive me.
No.
Did I answer your question?
You did. And if it's at all possible, I think it would be helpful for the committee to see those updated numbers of how many people are on the wait list, just so we know where it is, and maybe having a running total of how much we're paying in contempt of court fees for being out of compliance with statutory requirements would also maybe help motivate us to figure out and come up with other solutions. So I think that would be helpful. Kind of getting back to that, one of the things that I was probably most disappointed to learn is things that were not included in the governor's recommended budget. And in talking with some of the people that were not included in this, it seems like it was a very conscious decision, but I want to see if there's any reasoning behind this. You had talked about how there are other programs that are available that we're trying to do to get people treatment faster, to identify problems earlier on within our jails. I know that in our December 13th, 2023 interim finance committee meeting, we approved $14.9 million in ARPA funds, specifically for jail-based mental health programming for forensic clients, both down in Clark County and Washoe County. I know that I was impressed. I was initially hesitant because we were starting to be fined at a rapid pace, and we had these higher numbers of wait lists. And so in talking with, the Clark County Sheriff and the Washoe County Sheriff and talking about these programs, it seems like they are doing incredible work. And talking with the companies that are in there providing those services, they are, in addition to having some new beds, they are able to catch people quicker, and people aren't decompensating, people are getting on medication quicker, and we aren't running into some of they're preventing a lot of these competency things. Sorry, I'm doing a long speech here. I guess my concern is, obviously it's not in this budget, so I'm wondering if that was a conscious decision, if you can give us an update on how those funds are being utilized. I believe they have utilized about 5.3 million of those ARPA allocations. I know in talking with them, and I know they're present in this room today, so if committee members have any questions, I'm sure they'd be happy to come up and talk about their programming. But it seems like it's doing what we need it to do so we can get people moving and get them the treatment. So I was wondering if you could address that.
Cody Finney, for the record, thank you very much, Senator Wynn. I appreciate your spending time with us, because I recall that you were hesitant, and I appreciate the energy you spent to look at what we were doing, what we are doing. Yes, the jail, what we call the jail-based program, which is a little sort of a inconsequential name for a very consequential program, is not in the budget that I'm bringing to you today. During the process of developing the budget, there are just hard things, and sometimes the math just doesn't work in my favor. And so it is a very good program. Let me say this: it is having the desired effect. We continue to look for ways in which we might make adjustments. We just did not have we just could not make the math work at the time. We do have a wonderful report that shows how opioid dollars might be used, and how the intersections between this population and substance use, and how we would be preventing those things by operating in that way. So we continue to explore, while I support the governor's budget, we continue to explore things that are going to help people. And so I appreciate what you're saying today, and yes, it's true, I'm not bringing that to you.
Thank you. I appreciate your candor. And yes, I'm in a position where I was initially skeptical. Obviously, now I am looking at the actual data. I'm looking at a successful program. Obviously, when you see a program that is successful and can provide those services, that ultimately will reduce costs and get people into treatment faster, I would like to continue those kind of things. So I was just curious whether or not, if there are any alternative programs that the agency is looking at increasing around mental health with some of these populations.
Cody Finney for the record, and I would like to offer that Mr. Cross has detailed numbers on all of the things that we're talking about, if the committee would like to hear those. We have some, in these decision units, we have some additional staff that will be focused on some of those diversion efforts. There aren't alternative programs akin to what you were asking about.
Thank you. And then, Chair, I know I've taken a lot of the time. If I could ask one last question. This is kind of, this might be more appropriate for Mr. Robb. Just how long, I know that Building 3A, which we are set to open, it sounds like it'll be completed May 15th, that will provide some relief in those 21 additional forensic beds, is also set to be either demolished or a part of the Campus for Hope program. How long will we have these 21 beds that we just renovated and spent $9.3 million on? How long will we be able to utilize those beds while before the Campus for Hope project begins, one, and if we were to approve this new forensic hospital, that would take probably years and years to build out. So what is the plan for increasing forensic beds,
Cody Finney for
the
the record.
next 2 years, I guess?
Oh, my apologies. Cody Finney for the record. Building 3A is not ideal, and Mr. Robb and I shared some colorful language about my insistence that we needed those beds. So I will acknowledge that. But from the beginning of the discussions or the Campus for Hope, my position was we cannot impact the number of forensic beds that are available, and we cannot do anything that would prevent the construction of the new building. And by taking that position, I embedded myself firmly in the project. And so we continue to operate with those parameters. And I'll pause there and let Mr. Robb provide additional testimony.
Jack Robb for the record. Without a doubt, we will not disrupt anything that's going on at 3A with Campus for Hope. We have some maps that we'll be bringing forward in the future to show you. We're actually parceling that into 2 parcels to not deed over the first parcel or give that first parcel to Campus for Hope until the new forensic hospital is up. And the Campus for Hope is under a firm understanding that we will not disrupt those services until the new forensic hospital is complete. To complete that new forensic hospital, some other things have to occur, and relocation of some ADSD facilities that are on the Southern Nevada campus to a new building, and then demo those buildings, demo the solar field, and then build over the next 4 years the new forensic hospital. It is scheduled to be built within 4 years from this coming June. So that's our timeline that we have planned for the new forensic hospital.
So what is that timeline then? The new forensic building, which is located by the Campus for Hope, where these forensic beds are currently in 3A, it's 4 years if it's approved from June to 4 years from now. But what is the timeline for, so you would anticipate that 3A and these 21 renovated beds will remain there that entire time?
Jack Robb for the record, not only 3A, but 3. The 2 buildings are side by side. They're both forensic facilities. They're both mapped out in every agreement we have with Campus for Hope, and they cannot go away until we have something to stand in their place or addition to what there is there.
So all of the forensic beds, including the ones that are under renovation that are set to be complete with that 9.3 million in ARPA funds, they will at least be there until 4 years from now when that hospital opens. Just trying to clarify.
Jack Robb, that is correct. 3 and 3A will remain in place and operational until the new facility is up and operational.
And this might be another question. I appreciate and I'm glad that we worked so hard to get those 21 extra beds. I think that will alleviate the wait. Do we have any other plans? Obviously, I'm disappointed to hear that it's not a priority to continue some of this jail-based mental health like intervention services, because I think that might alleviate some of those numbers. But do we have any other plans to find additional forensic beds for the next 4 years?
Cody Finney for the record. At this moment, I do not have additional plans to find additional forensic beds other than the facility that would be completed in 4 years.
Thank you, Chair.
Thank you. Assemblymember Monroe Moreno.
Thank you, Madam Chair. And this is for Mr. Robb. Don't go anywhere. So my question is the $9.3 million that was in ARPA funds for that project for Building 3A, are we going to utilize and fully expend all of those monies, or will there be a savings from that project?
Jack Robb for the record, I was not prepared for that question. I should have texted with that question also. I did not. I can get back to you here in a minute.
Thank you. If you go ahead and send the text, and when you get it, let us know. Thanks. Thank you, Madam Chair.
Thank you. Next, we'll go to Speaker Yeager.
Thank you, Chair. I first want to observe it feels a little bit like Christmas in here because we have a lot of red up at the dais and we have a lot of green out in the audience. So I'm not sure what that means for today, but just an observation. I do have a few questions. This budget has always been very important to me. I think mental health is something that motivated me to run for office. And as we all know, the state has an obligation to provide mental health services. And we haven't always done a great job of that, but I think we are always getting better. So before I get to more specific questions, I just have a couple general questions about about budget 3161 based on your slides. So on slide 12, you had the fines from the district courts. And my question there was, I may have asked this before, so I apologize if you've answered it before, but are those fines really just from like one judge, one court, or are we being fined by various judges around the state? If you have that information, it would be helpful to know. If you don't, you could always provide it later.
Cody Finney, for the record, thank you very much, Assemblyman Yeager. And if I might just address Assemblywoman Monroe Moreno's question very quickly, our expectation is there will not be savings from that $9.3 million from our review of the construction project. Mr. Yeager, to your question, so the way they operate this is that the competency court is all with one judge, now both north and south. So it's from the competency court, primarily in the south. We have had some indications of certainly orders to show cause from the north, and some indication that perhaps both north and rural are seeing this as a motivational factor to keep us moving in the right direction on the timing of admitting patients.
Great, thank you. And if I could, Chair, the other question I had on slide 15, you talked about budget account E254 and the anticipated 1115 Medicaid waiver. And so I just had a question. We're going to get a new federal director of Medicaid. I believe hearings are happening now in Washington, D.C., but I think something that really hasn't been talked about is, I guess, the integrity of the 1115 waiver programs that the states have been doing. And we've obviously had some unusual, some groundbreaking and creative ones here in the state. So my question is just, have you gotten any indication from federal sources that any of the 1115 waivers that we already have or that we are in the process of trying to obtain might be in jeopardy with the change of the federal administration and the change of the federal Medicaid director?
Cody Finney, for the record, I have not personally received direct information of that. However, I work closely with my colleague, Ms. Weeks, to monitor what's happening in those areas. And we continue to watch all that very carefully because it appears that, we're in unprecedented times.
Thank you for that. And obviously I can ask the same question of Ms. Weeks, and I have been in touch with our federal delegation to try to make sure that there's a commitment at the federal level that we maintain the 1115 waivers because they're really important for the population that we serve here. But if you could just keep us updated if you are hearing anything, and we will do the same. Chair, if I could, I had some specific questions on E252, which is the continuation of the skilled nursing facilities for forensic patients. So, we had set aside some ARPA money, I believe. We'd allocated $5.7 million. And so my question is just if you could give an update on how that is going, and in particular, if you anticipate expending all of the remaining $4.6 million in ARPA money for this purpose, and what the plan and timeline is to do so.
Cody Finney, for the record, thank you very much. Mr. Cross is prepared to speak to the programmatic. It's my understanding we do expect to expend those dollars.
Drew Cross, for the record. Thank you for that question. I think we've explained in the past that we have a growing population of long-term clients within our forensic beds. We have 239 forensic beds. Over 35 of them are filled with individuals who are under a long-term commitment. That's either an indefinite commitment under NGRI or a long-term commitment for those who we were unable to restore that face serious charges. Having an avenue to place these individuals as they become more infirmed over time is a priority. We have had success with this program. As that population continues to age, we will continue to seek out partners in the community that have these skilled nursing facilities, which can provide the appropriate level of care as an individual ages.
Great. Just for the clarity of the minutes, NGRI, not guilty by reason of insanity, is that correct?
Apologize for the acronym. Yes, sir.
Thank you. Chair, if I could ask just a couple more on this budget. So given where we are so far with the ARPA expenditures, which is, we've spent a little bit, but there's still a lot left to spend there in terms of the full allocation. How did the agency determine that $1 million in general funds would be needed in fiscal year 2027 in this decision unit? And what would the impact be if we decided not to approve the $1 million in general fund for this purpose?
Thank you, Cody Finney, for the record. So that $1 million is the continuation, once the ARPA funding is spent down, of the long-term care services. And the impact would be that we would have to wind the program down and bring those patients back into the state facilities.
Thank you. And then one final question. Senator Wynn and I are going to hog all the questions today, I think, but we've been working on these issues for quite a while, so it's nice to be able to ask questions. With this program in particular, E252, have you explored all the options to maximize federal funds such as Medicaid for the support of this program?
Cody Finney, for the record, we explore those options on an ongoing basis to make sure that anything that is federally reimbursable can be reimbursed in that way.
Thank you. Assemblymember Monroe Moreno.
Thank you, Madam Chair, and I have a few questions, if that's okay. I'd like to go back to the answer you gave, and thank you for that answer. So if we're going to expend all of that dollars, do you anticipate there'll be a need for any general fund dollars to help finish that project, or will that be enough, those ARPA funds?
Cody Finney, for the record, we are not currently anticipating any need for general fund dollars to finish that project.
Perfect, thank you. And then I'd like to move over to E268, specifically the City of North Las Vegas Fire Department, the crisis response team. It's exciting to hear that that is so successful, but could you provide even more of an update on the status of that response team that they have, what impact the additional funding would have on the team's operation, and how the team is currently funded?
Cody Finney, for the record. Assemblymember Monroe Moreno, I would very much like to have Ellen Richardson Adams come up and talk to you about that. She is a superhero who does a lot of work for us and is an expert on this topic.
Good morning, Ellen Richardson Adams, for the record. Thank you, Assemblymember Monroe Moreno, for the question. So to provide a little bit of clarification, we operate two different crisis response teams in the Las Vegas area. So the one that's been long-term running has been with Las Vegas Fire and Rescue, with what is funded as Mobile Outreach Safety Team and is branded as Crisis Response Team. So you'll hear CRT and you hear MOST, but it is the same, excuse me, it is the same program. That has been operational since 2017. City of North Las Vegas Fire Department has adopted a similar response team, and same funding as MOST, branding is CRT. And so this enhancement unit, where theirs will be slightly different in operations, will have an opioid component with it. And so we'll be looking at a co-occurring component, so individuals who are experiencing mental health crisis and or an opioid substance component. And so the staffing is with City of North Las Vegas Fire Department, is they have their fire personnel respond to the normal 911 calls. When those calls come in that are related to anything with mental health opioid, then the fire response goes out, and then they have qualified mental health professionals that also assist on the team. So from a holistic person, this is a very solid and healthy response type, because not only is the person's physical health being reviewed, but so is their mental health. And so really able to determine in that moment of crisis what is the need and what is the best course of action to assist with them. And so it is a dual response between EMS and mental health professionals. And under the qualified mental health professional component, the eligibility is a licensed clinical social worker, a licensed marriage family counselor, or a licensed clinical professional counselor, CPC. Thank you.
Thank you. And that, I think, answers my second question, because I wanted to know, there's so many things in the governor's budget that is utilizing the opioid dollar, so I wanted to know how it was going to align. So currently, is this program being funded with grant dollars? Because I know a few years ago, North Las Vegas Fire Department got matching grants through the grant. So are they funding it through those grant dollars now, and we're making that switch?
Ellen Richardson Adams, for the record, thank you for the question. So the original pilot that they had started was through federal funding. That pilot was showing success and was showing positive upstream of interventions. When the opioid dollars came available, it was a conversation time of how could we really look at this and expand opportunity. And so it is a way to put forward a new concept. So it's growing in its intention and growing with its interventions and outreach. Does that answer the question, ma'am?
It does. Madam Chair, so do they already have the staff in place and they just need the funding to continue the program, or will they have to hire staff to help with that?
Thank you. Ellen Richardson Adams, for the record. They have their core staff in place, and this will help allow for some expansion for that and that growth. Thank you.
So much. Thank you, Madam Chair.
Thank you. I think we are actually headed back to Speaker Yeager.
Thank you, Chair. I have a question on M201, the caseload-driven new positions. This is the misdemeanor diversion program, which, by the way, I think is a great program because it's helped us free up beds. And I can't remember. I think we've been working on this program for maybe as much as 10 years. I remember 2015 when Senator Joe Hardy was here. I think we had a bill somewhat related to this. So here we are 10 years later, and I think the program is doing wonders. So my question there, though, is we have projections that caseload trends are going to continue to increase, I believe. And if you could just talk about how the recommended positions in this budget would impact services for eligible individuals in this program, please.
Thank you for the question, Ellen Richardson Adams, for the record again. Sir, you are so correct. I was part of that team that helped to develop that program originally back in 2013, and we rolled out in 2014. And it's been an honor to be part of that and to watch it just grow and flourish and to be able to touch the lives that we do. And so, caseload's important, right? And so to be able to see something that continues to grow with that upward trend is exciting. So thank you for asking that question and celebrating that with us. The intention of those positions is to help provide intensive supportive case management. And so under Medicaid, we're able to bill for targeted case management. What does that really look like on a daily basis, right? A client's not going to come and say, I got targeted case management. What they're going to say is, my case manager helped me find housing. My case manager helped me get to any follow-up court appointments, assisting in their medical health, their mental health, getting those appointments set up, transportation, housing assistance, and really being kind of that cheerleader for them and not giving up on them, even if they happen to make a little bit of mistake or miss an appointment. They're like, all right, let's redo this again and let's start back. And so they really become that core and heart of that program to help people with intervention and success. Thank you.
Thank you, Chair. And if I could, not a question, but yes, it was 2013, now that you mentioned that. And I just want to thank you for the work that you do in this program. It is, I think, vitally important. And, there's a lot of talk out there these days about getting rid of these type of diversion programs, and I think that's just absolutely the wrong approach, particularly on the misdemeanor side. As you mentioned, the more we can do to stabilize somebody, to get them treatment, to get them the help that they need, we keep them out of the justice system, we keep them out of felony charges, we keep them out of Ross and Neal or Deanie Townsend. And ultimately, that's number one, a cost saving for the state. But number two, it's just the right thing to do because we're helping somebody get back on their feet. So I know how time intensive and how frustrating it can be sometimes. And to your point, I just want to emphasize that we can't have an expectation that these individuals are going to be 100% compliant. I've said over the years that we should be incarcerating the people that we're scared of, not the people that we're mad at because they missed an appointment. And I think this program is a shining example of that. So thank you to you and your team for all the hard work that you put in to making this program happen. Thank you, Chair.
No, thank you. Mine should be an easier question. I'm talking about some of the position eliminations in the E606 budget. I see that there are 4 existing positions, including the one clinical program manager, auditor, administrative assistant, and consumer services assistant. I also heard that some of these you recently filled. So I'm just wondering if you could address how those recommended elimination of those 4 positions would impact operations and whether or not we should expect some changes now that that's filled.
Cody Finney for the record. Thank you, Senator Wynn. Again, I want to express my gratitude to the legislative staff who worked with us this week to identify to provide those adjustments and provide alternative positions because some of those were filled. So rather than the auditor and the clinical program manager, we identified 2 clinical program planner positions that are currently vacant, an alternative CSA position and an alternative AA position that we can move incumbents to. So no individuals will be impacted, and we're gonna examine how we got our wires that crossed, but and make sure it doesn't happen again. But we did offer a solution to that.
Thank you. I appreciate that, and I'd encourage you to keep working with our staff to make sure we can get some of that cleared up. I don't know how this happened, but probably because I know we have been working on this a long time. I'm going back to Speaker Yeager.
Thank you, Chair. These might be the final questions I have for today. We'll see. But I wanted to ask about E607. And in particular, in this budget, it kind of looks like the governor's recommended budget actually recommends reducing general fund expenditures by $3 million. I'm looking at this, and it looks like the need is increasing, but the ask of the legislature is decreasing. So a couple questions around that. Can you talk a little bit about what factors are contributing to the increased expenditures in fiscal year 2024, the projected expenditures in 25, and in particular in this transitional living, mental health court, and community diversion program? And do you think that trend is going to continue where the expenditures are going to continue to increase in this budget?
Cody Finney for the record. This decision unit is built to eliminate the increased expenditures. I think I will ask Ms. Richardson-Adams to speak to the programmatic impact of that. You can see she is the superstar.
Thank you, Ellen Richardson-Adams, for the record. That might be an overspoke, but I will take it. Thank you. Thank you very much for the question. So we have not given an increase to the housing providers that provide this service. What the increased need has been is the number of individuals who are in need of housing and housing assistance. Assistance might be financial support and or supervision and supportive skill learning. And so what we had done was we did work programs that from other categories to help supplement into our residential categories to address that increase of need. And so that is how we got here today. The need of individuals that we're serving, specific to your question, again, kind kind of coupling that with those individuals coming out of justice diversion programs, their needs are intense, especially in the beginning. And so it generally requires a higher level of need and cost to serve those individuals. Those assessments of each individual is completed at a minimum of every 6 months. Oftentimes every 3 months, but at minimum every 6 months. And so we look at their financial components, their skill development, and the need and level that they need for supports, and we make adjustments as needed. If they're able to reduce, we celebrate that, and we ensure that that takes place. If they are at the same level, we continue with that, and sometimes there is a need for increased level, and so we have to make financial adjustments to make that happen.
Thank you. Chair, if I could ask one follow-up on that question, so, or on this budget. So given the recommendation to reduce general fund by $3 million, do we think there is going to be adequate funding in this budget account for the upcoming biennium to provide these services to all eligible individuals? And if not, how would we go about determining who is going to receive services and who's not?
Thank you, Ellen Richardson Adams, for the record. That's a very tough question, so I will take it one part by one part. And if I forget one, please remind me. Given the categorical structure that's being put forward for the next biennium, there will be a little bit more constraint on what we'll be able to potentially ask for a work program to adjust our funds within our budget. I don't have exact numbers for that, but just at a quick glance, that was the observation. The impact and need will, how we look at that is we look at individuals with the most needs and those that would have, under a risk assessment, less chance of being able to independently navigate the community without supportive services and supervision.
Thank you, Chair. Not a question, but just a statement that, I think we have to find the right number on this budget account because this is investment that I think saves the state money in the long run, and if nothing else, is probably going to save us from being fined additionally by the courts for not being able to place folks in forensic beds. So obviously we'll get to that when we get to it, but I just wanted to recognize how critical these services are, and thank you so much for being here and for answering the questions.
Yes, thank you. I think next we will go to Senator Dondero Loop.
Thank you very much, Madam Chair. I want to discuss Decision Unit E652 a little bit. And can you explain how the agency would account for contract staff and its caseload staffing, analysis, and ratio?
Thank you, Senator Dondero Loop. Cody Finney for the record. Your question is, I just want to make sure I'm understanding the
So
question.
I just want to know how the agency is going to account for the contract staff in the caseload staffing, analysis, and ratios.
So the mechanism that I understand that we've used for that in the past is those approved ratios for state FTE. But it's an interesting question, and budgeting it this way, while it's true to how we've operated in the past, because we've long used work programs to move Category 1 money to Category 8 and operated with contract staff when, frankly, the staff are preferring to work that way. We'll continue to monitor those caseloads and reconcile how that would work. What is true is that 12 state FTE doesn't buy 12 contractors. So the caseload is approved for the state FTE price, and we get fewer physicians for the contract price.
And that begs the question, right? So thank you. So can you then provide a little additional information about the impact to the agency's operations if that reallocation of expenditure authority is not approved from the contract staff?
If Cody Finney for the record, forgive me. If that reallocation to Category 8 is not approved, this would impair our ability to provide services. The elimination of those positions would impair our ability to provide services without it going into the contract category.
Thank you very much. I know that we all recognize how important it is to treat and support mental health. And so the contract versus, staffing is a big issue. So thank you very much, and thank you, Madam Chair.
Do we have any other questions on this budget before we move on to the next one? Looking around, I don't see anything. I mean, I would just encourage your staff to continue to reach out to work with us on some of these budget items contained in here. I know we are all wearing green, well, I'm wearing Rebel Red, but I know people are wearing green today, not only for Children's Week and recognition of mental health, but obviously we are dealing with behavior and mental health here today on with these budget presentations. And I would hope that some of these programs that have been instituted, we would do a better exercise on the real savings that we would have with shorter stays, quicker treatment, lower recidivism, faster case resolution, not only for court systems that's already crowded and, overcrowded, but also giving some quicker justice for victims within the system as well. So hopefully we will be able to fund some of these programs that have a proven record of success. So with that, I will close the hearing on that budget, and we will move on to 3162, Northern Nevada Adult Mental Health Services. Go ahead and begin when you're ready.
Thank you. Cody Finney for the record. On the 3162 Northern Nevada Adult Mental Health Services, this budget does not include the Northern Forensic Inpatient Facility, as I mentioned previously. Rather, it is the Deanie Townsend Hospital and the outpatient services in the northern region. All right, M201 is the decision unit for 8 positions. These are previously legislatively approved caseload positions, primarily to address the similar types of casework for folks we're trying to either divert from the criminal justice system or keep out of the criminal justice system on the other side of that, and some additional staff. E254, again, anticipates the approval of the 1115 waiver and removes the amount we anticipate would become reimbursable given that approval. E606 on slide 20 eliminates 4.5 positions that have been chronically vacant, and these are all vacant. E652 eliminates 13 FTE. Those are 13 psychiatric nurses and 1 part-time mid-level practitioner. And that decision unit also moves the funding for those positions into Category 8, as we discussed in 3161, to allow us to operate with contract staff, as we historically have, but avoiding the work programs that we've done in the past for that. I'll pause for questions there on 3162.
Thank you. We will start with Assemblymember Howdicke.
Thank you, Madam Chair. And I have a couple of questions, if that's okay. On my first couple of questions are regarding the caseload-driven new positions, and we'll start with the mental health counselors. I know there's 1 for the outpatient assessment program and 2 for the outpatient counseling program, so a total of 3 there. And I love the idea of, more positions to reduce the caseload that each counselor has. So can you just talk to us a little bit about how you guys got to those metrics, how you guys got to this ratio of caseloads per counselor?
Thank you, Cody Finney, for the record. As you can see, I've been joined by Julie Linsmith, who is the manager of these services directly, and I'm going to ask her to speak to the specifics of those positions.
Thank you. Julie Linsmith, Agency Manager at NAMS, for the record. We have not changed the approved caseload ratios. It's still 50-1. We've just seen an increased demand for counseling services. As mentioned, we're seeing the largest growth in our diversion programs and court programs like AOT and mental health court. And these individuals need more intense care, and so more and more of them are getting counseling in addition to case management and other services like medication management. Thank you.
Thank you. And I want to ask now about the psychiatric positions. The same question. I know you're looking for an additional psychiatric caseworker, 4 additional psychiatric caseworks, and then 1 senior psychiatric position. So can you talk to us the same thing? What's happening here? What's causing the increased caseload, and what would the addition of these new positions mean for your operations?
So Julie Linsmith for the record. We are seeing an increase in the acuity of the clients we serve, and those more acute programs require more intense, lower caseloads. So we need more workers to adjust for that acuity. We are diverting a lot of people from Lakes Crossing and the criminal justice system, and these programs are essential for that. They do the day-to-day work.
Thank you. And I know how important these positions are. And, you know, in this budget, too, you talk a little bit about eliminating positions that are vacant right now. And so how confident are you that you'll be able to fill these positions?
Julie Linsmith for the record. The psychiatric caseworker positions have not been challenging to fill in the past. I don't know if that will continue, but our vacancies that are hard to fill are usually our psychiatric nurse positions and our psychiatrist positions. So we feel like we'll be able to fill the psychiatric caseworkers and the mental health counselors.
No, thank you. I think next we'll go to Assemblymember Brown May.
Thank you, Chair. Thank you so much for the opportunity. I apologize for missing the beginning of your presentation. I was delivering a bill presentation in another committee. It's really good to see you this morning. I am also wearing green, right? Mental health is so very important to all of us, so thank you for your efforts there. My question is about Decision Unit E606, which is with regard to the position eliminations. You talked about the 4.5 vacant positions that are here proposing to be eliminated. They are vacant, right? But my question really is, though, about the vacancy rate. I understand, while I believe it's higher in the South, that NAM's budget has approximately 27% vacancy rate. So what are the vacancies in your division? What does that do to the overall operations and delivery of service, especially for the clinical staff?
Cody Finney for the record. We have had a high vacancy rate. We're seeing some improvement in many of those rates. Ms. Linsmith in particular, when she started, had a vacancy rate over 50%, and she's done amazing work to get that down and continues to do so. So that Decision Unit E606 eliminates 2 lab positions and a pharmacist. Those positions really, those positions in particular, we've not seen the demand for. So she's been managing through the change, the continued change that we've seen in what kinds of services are needed and what kinds of services we need to provide as the safety net. So progress being made, but it is challenging. I am told that we're seeing more interest in psychiatrists working directly for us than we have historically. Related to some other forms of employment not being as stable as maybe they have historically, or needing benefits, some of those kinds of things. So that's encouraging, particularly related to psychiatrists. But the progress is being had, and we do have some folks who prefer to work on a contract basis rather than be state FTEs. So that flexibility does help us.
Thank you. Follow-up, Chair. Go ahead. Thank you. Thank you for bringing up contract staff, right? Because that's my next logical question. And I heard you state as I walked in that it's not an FTE for our contract staff, right? And so there is a Decision Unit E652, which recommends elimination of state positions for contract expenditures, right? Can you provide some additional information or context about the potential impact to the agency's operations for the, if this reallocation doesn't happen, if that expenditure authority is not approved for contract staff, what's the implication into your agency?
Thank you, Cody Finney, for the record. If those positions were eliminated without reallocating those dollars to Category 8 and allowing us to hire contract staff, it would impair our ability to continue to provide services at the level we currently are.
Thank you. One last, Chair. Thank you so much. So I just want to clarify and get on the record and a personal question, right, relative to the finances and how we're operating the division. If we're not switching out an FTE for a contractor, and let's just say a contractor has more flexibility in hours, are you negotiating individual contracts with hours or expectations that are specific for each of those contractors? So I'll give you the clinical psychologist. Says I can only work Monday and Tuesday from 6 a.m. to 1 p.m. Is that something you're negotiating into individual contracts, right? Are we that specific in our expectations as we're working with contractors?
Cody Finney, excuse me, Cody Finney for the record. We do have contracts. We have a variety of ways we work with contract staff through agencies directly. Really, that flexibility is something we continue to try to work towards so that we can get work with people who, for example, only want to work 2 days a week. So yes, some of the contracts are that specific. I'm sorry, my mind went to therapy at 6 a.m. Forgive me. But we do work specifically with a variety of individuals who have a variety of restrictions, and some who want to work, lots of hours. So yes.
Thank you. Do we have any other questions regarding this budget? Seeing none, looking around, I don't see anything. We'll go ahead and close that, and we can move on to our next one, the Behavioral Health Prevention and Treatment Budget, 3170. Go ahead and begin when you're ready.
Cody Finney for the record. Thank you very much, Chairwoman and committee members. We'll move on to the overview of Budget Account 3170. This is our Behavioral Health, Wellness, and Prevention Unit. I think of this budget as the public health part of behavioral health. So until now, today, we've been talking about where we provide direct clinical services to patients. This unit doesn't do that. This unit manages grants, does some oversight and technical assistance with the community, and tries to incubate practices that are beneficial. Our work related to substance use is largely focused on this unit. They do pay for a few services, a few direct services. All right, so on slide 22, we have 3 enhancement units that are requesting state FTEs that are funded with federal dollars. These grants are all currently, as far as the information we have to date, stable and in alignment with the current federal administration. So for E225, those positions are for the state opioid response, and this would help us to establish the infrastructure managing that opioid response grant, that large grant. Their current positions are contract. This is a 3-year discretionary grant from SAMHSA. Next, we have E226, which is 3 positions, mental health counselors, to establish a certification program that is needed in this budget account. And finally, we have E227, which is 3 full-time positions to manage the substance use treatment recovery grant. They they've recently changed the name of this, and I must admit I'm struggling. The Substance Use Prevention, Treatment, and Recovery Grant. This would allow the Bureau to set up higher quality programs and increase our technical assistance and partnership with our community providers. All right. Next, on slide 23, we have enhancements units related to the Community Mental Health Services Block Grant. This block grant historically has been funding to help us develop community mental health services for individuals with serious emotional disturbance and serious mental illness. So this isn't generally providing direct service, but rather encouraging the development of those programs by private providers for this difficult to treat population. It's also historically paid for some services that are not Medicaid reimbursable. However, no inpatient services are paid for here. So that request is for 2 staff members that would replace contractors and manage that oversight of the block grant. Next, we have E231, the Partnership for Success Grant. This one focuses on the prevention of youth suicide, and this requests 2 positions that would be overseeing the grant objectives and managing that grant. E232 is a decision unit for the Garrett Lee Smith Award. I'm sorry, I think I said youth suicide prevention. Please forgive me and allow me to correct myself. E231 is Partnership for Success, and that focuses on substance use prevention. I believe I may have said suicide prevention. E232 is the Garrett Lee Smith Award and is youth suicide prevention. So this is this grant supports the Department of Education to enhance infrastructure surrounding suicide prevention efforts, and this position would allow us to fulfill the grant management and other obligations related to the grant. On slide 24, we have 3 enhancement units that are expenditure offsets, and these are funds being transferred for positions 2 with the Office of Analytics that provides the data related to opioid and overdose and these prevention and treatment functions, and also a position with the Attorney General's office that works to manage their substance use working group and link those pieces together. As you know, they do a lot of work on substance use. All right, and finally, on slide 25, we have position transfers from budget account 3170 to budget account 3165. These are staff that are in the Office of Suicide Prevention, and that aligns with that larger work that we're doing on crisis response. So not just responding to suicide prevention, but responding to crises before people are to a point of feeling suicidal. And those crisis lines, all of that work is interlaced and working together. All right, so we will take questions on budget account 3170.
Thank you. I appreciate that. And we will go first to Assembly Member Monroe Moreno.
Thank you, Madam Chair. My questions are going to be on E900, the transfer of the Office of Suicide Prevention Programs. There's, looks like 3 positions that you're looking to transfer, but you're going to keep 1 in. Could you tell us what the challenges are that are experienced with the budgetary location of the Office of Suicide Prevention, and how would this recommendation to transfer to the crisis response budget account address any of those challenges?
Cody, I am so sorry. Cody Finney for the record. So one current position is general fund, and we are not mixing that in budget account 3165. We examined a number of ways to make this transition and determined that a number of mechanisms could be correct, but that what we've proposed here is as correct as any of the others that we determined. And so, but we did want to keep that general fund separate, as is sometimes a concern, and that stays in 3170. The funds for Healthy Nevada that currently fund some of these Office of Suicide Prevention staff align nicely with the 3165 mission and the 988 crisis response mission, and so that's how we've landed on this.
Madam Chair, I think that also answered my second question that I had was, why was the decision for the existing unclassified statewide suicide prevention coordinator position not included in the change? So
I think it does. Thank you so much for that, Administrator Finney. I have some questions moving to some of these new position recommendations there's a bunch of them, regarding E225, 226, 227, 229, 231, 232. If I can bring your attention to that. I mean, I realize that these new positions are 100% funded by these federal grants. Obviously, I have some concerns on what kind of services our community might lose if any of that federal funding goes away. But even with that being said, assuming everything is going to stay in place, right now these services are all contracted out with subcontractors. Am I correct in understanding that? Own a friend.
Yeah, Cody Finney for the record. Right now we have some contract positions. Not all of it is subcontracted out to subcontracted organizations, if that's your concern. But Shannon Bennett is here with us with exquisite detail about these things that I'm sure will be helpful to you.
Thank you so much for the question. Shannon Bennett for the record. I don't really have anything to add to what Ms. Finney said. We do sub-award out to our community, as you likely know, for a lot of these services, but we do have contractors in place to help us manage the details of the grant right now. So I don't, it's really just a reduction of our contract staff for the state positions.
I'm just curious because do we have a problem with the contractors that are doing that? Is there a conscious decision to take those 17 positions and bring them in-house? Kind of what is the thinking behind creating those 17 new positions here instead of keeping them already out in the community with those contractors that are already doing this work?
Cody Finney for the record. I do think we have a miscommunication in that we have contract staff that are individual contracts sitting with us to provide this work, not contracted out into the community. So that what we're talking about replacing here are individual temp contracts that are people currently sitting in our office. We are not talking about reducing the subawards that go to our partners, particularly.
And that probably, I should have used that terminology, those subawards. It's still your intention to utilize those subawards. These are just positions to help administer those monies?
Cody Finney for the record, yes. When we bring these grants in, we have created contract positions to help with the administration. We absolutely will continue to subaward the bulk of the dollars for these awards to our partners in the community with whom we work that provide the actual services.
I guess my question is, 17 new positions is quite a bit, and you haven't been operating with those 17 positions up till now. What is the change in wanting to have those 17 positions work with those subawardees? Like, why are so many needed, I guess?
Cody Finney for the record. You know, our goal here is to provide a higher quality of service to our community. There have historically been some areas where we contracted full programs out and had them managed with other agencies. Our goal here is to really, what we believe is appropriately manage where we are the fiscal responsible party, and make sure that we're managing that ourselves, and then contract those services out to the community that they can do best, for example, some of that technical assistance that is truly clinical technical assistance. We have partners at the university that do that fantastically, where we're doing grant mechanics technical assistance. We'd like to be able to do that better with these staff positions. So that's really where we're trying to separate that out.
So I'm looking at like the information that you provided regarding the State Tribal Youth Suicide Prevention Grant. It obviously is recommending 1 FTE, but you know, the request is 1.4 million over the biennium. And so that obviously the position isn't, you know, $718,000 a year. So most of that is still going to continue to pass through to those sub-awardees.
Cody Finney for the record, correct. Yes, that grant in particular, if I recall correctly, does work with the school districts. And so most of that money will continue to go to those suicide prevention services. The person will help us manage that and make sure it's happening in a timely manner.
Thank you. I think that answers some of my questions, although I may have some follow-up after today's meeting. Does anyone else have any other questions regarding that? No. With that, I know we have another question here from Senator Dondero Loop. I think kind of following up with some of these concerns too.
Thank you very much, Madam Chair. I want to address decision unit 490, 491, and 492. And can you let us know how many individuals are currently receiving services through the expiring federal grant programs identified in those decision units? We've got nonprofits and, you know, university organizations, and it's causing a little bit of angst.
Cody Finney for the record. Senator Dondero Loop, thank you for your patience. We're looking for those decision units, as I did not have those numbers in the slide deck. Might you be willing to repeat the decision units?
I have E490, E491, E492.
Thank you so much for your patience. Cody Finney for the record. So E490, that is an expiring ARPA project that was, so there were a number of ARPA projects, as we all know. That one went directly through the mental health block grant, and so that is sunsetting. Excuse me. The E492 is a similar situation with the substance use block grant, that they pumped money through that for ARPA, and that is sunsetting. So those overall block grants continue, but the ARPA additions to those are sunsetting.
Okay, thank you. And so will you then talk a little bit about how those reductions in those federal funds are going to impact those individuals in the community with those supported services?
Cody Finney for the record. I'll certainly start, and then Ms. Bennett may have additional detail. One of those issues is an assertive community treatment team, and I know this committee heard some about that from Ms. Weeks in her presentation. Assertive community treatment used to be referred to as a hospital without walls. This is intensive services for individuals with serious mental illness. And so our hope and intention is that will continue to be available to the people that need it through Medicaid reimbursement. They're working at Medicaid to set up a rate that would allow those kinds of programs to continue. Assuming that stays on track, that would be the sustainability plan for that particular service.
Okay, thank you very much. I just always feel like we're on this roller coaster with the people that need us the most. So thank you very much, and thank you, Madam Chair.
Thank you. I had time to think about just one further question backing up to that. Sorry, it just anytime I see there's such an expansion of like staffing, like with that 17 new positions for those federal pass-through positions, with no real indication that there was a problem. I'm just curious on that. I'm still curious on that and the decision making that went behind that. But do you anticipate that you're going to have any problems filling any of those positions?
Cody Finney, for the record. I don't anticipate particular problems filling those positions. We've been doing fairly well with that. I'm contemplating that that you mentioned there was no indication that there was a problem. We certainly would be happy to discuss the history that got us here. My perception is that historically we aggressively did not take on some of these responsibilities, and I believe we're preventing problems by making these corrections at this time.
Thank you. I appreciate that answer and my follow-up questions and your patience with me while I asked a ton of questions along with Speaker Yeager today. Do we have any other questions from committee members? Well, I think you're off the hook for today. So with that, I will close the budget on our last budget on 3170. I see that our chair has returned just in time for public comments, so I can turn that right back over to her.
Thank you, Vice Chair, and thank you, everyone, for a great meeting today. And with that, we are on our last item for the day, which is public comment. If you're here in Carson City, you can start filling in the table. And today we will have 2 minutes. Please don't forget to state and spell your name. If you are going to call in, the number is 888-475-4499, and the meeting ID is 820-8031-0699. And with that, we will start here in Carson City. Don't forget to state and spell your name for the record.
Good morning, Chair and members of the committee. My name is Joshua Martinez. I'm a captain with the Las Vegas Metropolitan Police Department. My name is JOSHUAMARTINEZ. And I just wanted to talk about our SMART program that we have in the Clark County Detention Center. That is the competency program that has allowed the jump starting to help reduce the days that you heard today from 129 to 74. So the Detention Service Division, along with the Nevada Department of Public Behavioral Health and Recovery Solutions, launched a 60-bed specialized mental health and recovery treatment SMART program at the Clark County Detention Center in June of 2024. The SMART program was created for those individuals that have been declared incompetent to stand trial by the state courts or have since returned to the jail following a state hospital stay. Since its inception, the SMART program has continuously maintained a daily average of 55 patients enrolled in the program, and a total of 255 patients have been enrolled since June of 2024. Finally, 16 patients have been recommended for reevaluation and have been found to be competent through the program. The SMART program includes admission screening and assessments, individualized treatment planning, intensive day treatment structure, individual and group treatment, psychiatric services, medication and medication monitoring, dedicated mental health team, specialized jail module dedicated to the program. Success from the SMART program, 255 patients enrolled, as I said, since June of 2024. 16 patients have been found competent through SMART, 55 patients on the daily average, and 87% of patients are 90% medication adherent. So those are just some of the highlights from our program. I appreciate the chair and the committee's time today. Thank you.
Good morning, Chair. Joanna Jacob, Jacob, no S, please, on behalf of Clark County. And I'm here to concur with the comments from Captain Martinez to my right. Clark County has been working with Metro historically on a number of programs, and the SMART program is one in which we jointly appeared before IFC in December 2023, referenced earlier today, to start this program with ARPA funding. I can say from Clark County's perspective on behalf of our public defender, and also based on conversations I've had with the district attorneys, is that we collectively believe that this program is making a difference in our community. I can also say that there are some challenges with our budget to continue this program absent state support for this program. And so we would also like to be part of the conversations referenced today to see if there is an avenue to see if we might be able to continue this very successful program. It is making a difference in our criminal justice system in Southern Nevada. So thank you very much.
Thank you, Madam Chair, members of the committee. For the record, my name is Jason Frierson, Frierson. I am with Cornerstone Government Affairs on behalf of Recovery Solutions. The SMART program was the result of a collaboration in June of 24 to start the SMART program in order to get folks stable. I have been in your shoes, obviously, and understand the difficulty with respect to budgets and crises. However, this is one of those areas where the budget columns don't necessarily line up to reflect the actual savings. What we're talking about is ending a program that is resulting in a shorter amount of time that individuals are staying in state institutions, costing the state much more money. It just happens to be in a different budget, where we can get folks stabilized and have an incredible improvement in recidivism by getting folks on a plan and making sure that they don't come back through the system again. I won't repeat any of the statistics that Mr. Martinez provided, but I think another interesting component of this is staffing. And we all have seen challenges when it comes to mental health and staffing and turnover, because it's a really stressful and difficult area to work in. But I can say over the last 2 years with the SMART program, they've lost 1 FTE. The staff are extremely rewarded in this work, and it's something that everybody is committed to. And again, I empathize with the difficulties of budget challenges, but I think that we have to look outside of one particular budget to make sure that we're not costing the state more money in the long run. So thank you.
Good morning, Chair, members of the committee. Mary Sarah Kinner, Kinner, with the Washoe County Sheriff's Office. Similar to Metro, we implemented what we have called a jail-based mental health unit. From September 1st of 2024 to 2/13/2025 in Tier 1, which is a program where we improve mental health, the abilities enough to be considered for treatment, or jumpstart the treatment in an effort to reduce the time needed at Lakes Crossing. 32 individuals were served. Of those 32 individuals during that time frame, 16% were reevaluated and diverted, which is the 100% success rate, within 20 to 42 days. 100% of the 32 individuals maintained or improved medication adherence. In 30 to 60 days, 57% of those 32 individuals saw significant symptom reduction. 60 to 90 days, 83% of the 32 individuals saw significant symptom reduction. We have seen great success with this program in a very short period of time. Similar to Clark County, however, we will be in a position where we're looking for some funding to continue the program. Thank you.
Good morning, Chair Mosca. For the record, Cadence Matievich, representing Washoe County, CADENCE Matijevich. You've heard some great statistics this morning from both Washoe and Clark County about what kind of difference this program is making. Behavioral health resources are a priority for Washoe County across our entire community, including those folks who are currently in our jail system. One point that I want to drive home, and Mr. Frierson talked about this, we strongly believe that this is saving number of bed days in Lakes Crossing. Not only are we helping these people ahead of their time in Lakes Crossing, when they return to our jail after being restored to competency, we can make sure that they maintain that competency, that they don't decompensate when they're back in our jail and then have to go back to Lakes Crossing. We think that this has benefits all across the spectrum, and we would ask, we recognize again that this is a challenging budget environment, but we believe that these dollars invested here pay dividends well beyond just these budget accounts. Thank you.
Good morning, Chair, members of the committee. My name is Mike Draper. I'm a partner for our Argentum partners. I'm here today on behalf of NAFCARE. NAFCARE provides healthcare services to jails and prisons all over the country, and we're the partner with Washoe County on the jail-based treatment program. Rather than repeat everything that's been said, I do want to say that we run programs like this all over the country, and Washoe County is indeed a model program for us. In a short amount of time, we've seen immense success. They've been tremendous in how they've implemented it, and we truly believe and can show that there's long-term savings by implementing programs like this. So we strongly encourage this committee to work with all of the partners to try and figure out a way to continue these programs. Thank you.
Thank you. And with that, we will go to Las Vegas. Anyone in Las Vegas for public comment? Seeing none, we will go to the phone lines. AVH. Oh, never mind. I'm sorry. Come on over. You're good. Oh, see, yes, everybody could fill the table who would like to speak from Las Vegas. And please don't forget to state and spell your name for the record. It's easier for our committee secretaries when they're doing the minutes. So you may start when you're ready.
Good morning, Chair and committee members. My name is Jamie Ross, R-O-S-S. I'm the director of the Nevada Statewide Coalition Partnership, and I am speaking today about the DPBH Behavioral Health Prevention and Treatment Category 11 for Primary Substance Use Prevention Funding, which has been
I'm sorry, and
proposed
if
to
you don't
change
mind
from-
going closer to the microphone just so we can hear you. Thank you.
Of course. Shall I start over?
No, you could just keep going.
Okay. Thank you. Which has been proposed to change from funding certified prevention coalitions. The purpose of this funding since its inception has always been to go directly to the communities through an established prevention coalition. Mike Wilden and Sheila Leslie helped create this system and has been supported and sustained by Richard Whitley to address the disconnect between the state and local agencies, mismanagement of funds, addressing specifically local needs. This ensures that our local coalitions are able to grow community capacity of our local agencies, ensuring that the state serves as the oversight body and not the direct funding body. Currently, our coalitions fund 38 agencies with this fund, historically up to 73. I am concerned about the overwhelming our state with at minimum 38 additional contracts and its sustainability, nor do I believe that these are the purpose of the funds. Thank you very much.
Thank you. And you can continue in Las Vegas.
Good morning. My name is Art Perillo, A-R-T-P-E-R-I-L-L-O, and I'm the Assistant Fire Chief of Emergency Medical Services for Las Vegas Fire and Rescue. I'm here today to support state grant funding for Mobile Outreach Safety Team and Crisis Response Team, or CRT, from account 3161 from Southern Nevada Adult Mental Health Services. The Las Vegas Fire and Rescue Crisis Response Team began as a pilot program in 2016 and has grown to assist over 3,000 individuals annually. Before CRT, people in crisis had two main options, the ER or jail. In 2024, CRT successfully diverted over 70% of behavioral health related cases to appropriate care facilities, shelters, or on-scene crisis intervention. Beyond the immediate response, CRT integrates caseworkers who provided over 5,000 follow-up contacts in 2024, reducing 911 reliance and improving long-term outcomes. The program employs a multidisciplinary team, including licensed clinical social workers, social work interns, caseworkers, and medical providers. In July of 2024, we doubled our response capacity and in 2025, we embedded a licensed clinical social worker in our 911 dispatch center to enhance crisis response and explore telehealth options. Despite substantial growth, CRT remains cost efficient. In 2024, the City of Las Vegas began funding medical and transport services, supplementing the grant with $1.5 million for crisis transport. Research shows that crisis response models like ours reduce insurance costs by 23% and inpatient hospital costs by 79%. As demand for crisis intervention service grows, continued funding is essential. CRT has proven to be an effective, cost-efficient, and a compassionate alternative to traditional crisis response. Please support this vital program to continue saving lives and strengthening our community. Thank you.
Good morning. My name is Steve Smith, STEV-SMITH, and I am representing SQS Consulting. I'm here to support budget account 3161 for Southern Nevada Adult Mental Health Services, the administrators, and Las Vegas Fire and Rescue CRT members. Over the past 4 years, I've been a member of the LVFR Behavioral Health Response Working Group, which aims to design an effective 911 and 988 behavioral health response program with limited funding support. The funding for the Mobile Outreach Safety Team has been crucial for LVFR CRT to respond to 911 calls for individuals in crisis. This funding enables us to provide essential on-site services, ensure safety, and coordinate follow-up care. LVFR CRT operates on an EMS-based model that Chief Perillo described. This approach ensures that medical evaluations are conducted to address increasing complexity of emergency situations that involve medical, psychological, and social factors. LVFR CRT EMS model is designed to augment, not replace, existing behavioral health programs developed by jurisdictions outside of the City of Las Vegas. LVFR CRT also responds to behavioral health requests from our law enforcement partner, Las Vegas Metropolitan Police Department, outside the boundaries of the City of Las Vegas. LVFR CRT EMS model has been presented to our Northern Nevada partner agencies as an option for them to consider as part of their behavioral health response plan. The administrators at the state and local level have been instrumental in providing LVFR with direction and concept feedback as our response model continually evolves. This allows us to serve an increasing number of clients through the LVFR CRT program. They have also offered us guidance on Medicaid provider type certification for insurance reimbursement, which would generate revenue to offset program expense and contribute to program sustainability. The data collected by the LVFR CRT program is being analyzed to enhance the future LVFR behavioral health program, which aims to include 988 health response with a designated mobile crisis team. We're grateful for the funding support to the LVFR system from the Southern Nevada Adult Health Services budget. Thank you.
Good morning, Chair and members of the committee. For the record, my name is Joseph Calhoun, Josephchalhoun, Fire Chief for the North Las Vegas Fire Department. I am here to speak in support of Budget Account 3161, Decision Unit E268 for the North Las Vegas Fire Department's Crisis Response Outreach Program. I've been in the fire and emergency medical services since 1994, and as technology and community needs have evolved, so have our duties and responsibilities. The most significant changes over the last several decades have been to focus our mission on being more proactive within the community. These proactive efforts focus on preventing illness and injury and truly helping our residents to find resolution to their problems instead of simply putting the proverbial Band-Aid on their wound. One of the most significant changes to our mission has been to address mental health issues. The City of North Las Vegas Crisis Response Team, working within our fire department, has the ability to respond to these situations in the field, armed with the skills to often de-escalate a difficult situation. They thoroughly evaluate the problem, getting the person to the right place to address their issue, and ensuring that they are connected with the best network of community services to assist them on a long-term basis. The need and mission continues to rapidly evolve as the mental health crisis is often overlapped by the opioid issues plaguing our country. and so we must pivot to find the best solutions. Your support of these funds will allow us to continue this mission, expand our crisis response services, and partner with us in our department's mission, our city, our people, our duty. I cannot express my thanks enough for the time to speak on this matter and for considering support of this essential program for the North Las Vegas community.
Good morning, Chair and members of the committee. My name is Justin Campbell, JUSTINCAMPBELL. I serve as the Deputy Fire Chief of Operations for the North Las Vegas Fire Department. I'm here today in support of Budget Account 3161, Decision Unit E268 for the North Las Vegas Crisis Response Outreach Programs Fund for a Resilient Nevada. As Operations Chief in our department, I oversee the Crisis Response Team, or CRT. I have seen the positive impact that the CRT has on our community. With mental health and opioid-related emergencies on the rise throughout our state, the CRT has offered an avenue for people in crisis to get better, more focused treatment without overloading our local emergency rooms. Prior to having CRT in North Las Vegas, people suffered from mental illness or substance abuse complications would all be transported to an emergency room. Many times, these people would not be in a state of immediate danger and did not need to go to an emergency room. However, since the implementation of the CRT, we now have mental health professionals and EMTs that make an on-scene assessment and determine the best treatment for people experiencing a mental health crisis or opioid addiction-related issue. This response provides immediate support to the individuals and the families. We now have the ability to transport people to a more appropriate facility that can directly treat the underlying problem, and we can connect people with resources that will lead to recovery. In 2024, a federal earmark provided funding to start the CRT. Without funding from the state, our CRT program will no longer be operational. Without an operational CRT in North Las Vegas, people will not receive the appropriate treatment and our emergency rooms will continue to be overloaded. With state funding, we will not only be able to continue our current program, but we will be able to add programs that are more specific to the opioid crisis. I would like to thank each of you for your consideration and your hard work on this legislative body. Thank you.
Thank you. Anyone else in Las Vegas? Thank you all for your service and for being here with us in our meeting today. With that, we will now go to AVH for anyone on the phone line.
Thank you, Chair. If you would like to provide public comment, please press star 9 now to take your place in the queue.
Hello, can you hear me?
We can hear you, caller. If you could state and spell your name for the record, and then you may begin.
Yes, ma'am. My name is Laura Osland, Laura-Oslund, and I am the director of PACE Coalition, Partners Allied Towards Community Excellence, and I cover Elko, Eureka, and White Pine County, and I am also the chairperson of the statewide partnership. And I'm here speaking today about the DPVH Category 11 Primary Substance Use Prevention Funding, and I just kind of wanted to give you some information on how the coalitions work and what we do with the funding. PACE Coalition and the 9 other coalitions in the state use some mix of this funding for direct prevention trainings and awareness in our communities. We sub-grant out the majority for prevention through other agencies and organizations. We do naloxone trainings and distribution. We do drug take-back days, and we contract work for prevention programs in our schools and other agencies and organizations in our communities, and for building resources, among other activities. We work with the 12 sectors of society, so youth, parents, businesses, media, schools, youth-serving organizations, law enforcement, faith-based organizations, civic and volunteer groups, healthcare, state and local government, tribal, treatment, and recovery. We convene, we bring people together to work towards healthy communities. One of the benefits to this form of funding through the coalitions that there are a number of smaller agencies and organizations that we fund that would not have the capacity to receive this funding were it not for the coalitions. Another benefit is that even some of the organizations that receive funding directly from the state and federal government would not write for the amounts that we provide, and the programming would not happen in our communities. The last benefit that I would like to highlight is that the coalitions know their communities and are involved in our coverage areas and in state and federal boards that work towards health and wellness and substance abuse prevention. This helps ensure that the funding is provided in a manner to prevent duplication of services and have best use in our communities. Thank you.
Thank you. Next caller. Caller, if you're speaking, we do not hear you.
Good morning, members. Can you hear me?
Can hear you now. Thank you. Please state and spell your name for the record.
Good morning. My name is Tammy Sheminsky, Shemenski for the record. I am Executive Director of Churchill Community Coalition, serving Churchill County. In reference to Category 11, 3170 General Fund specifically, these funds are very valued by our coalitions across the state. These funds literally cover every county with prevention efforts in which we know can save our state thousands downstream. The coalitions can reach the majority of the population and lead Nevada into a healthier era, both physically and mentally. I urge you to consider the lives that are saved, placed back on track, or continue on a healthier path because of the force each coalition brings to their area served. These funds make that possible. The impact of the funding is crucial in the ability to serve our areas with needed prevention. Thank you for your time and consideration.
Thank you. Next caller.
Good morning. Good morning, Wendy Madsen, Madson, with Healthy Communities Coalition. I would just like to echo the importance of the continuation of funding for our jail diversion, mental health, and crisis response programs. And I ask that you please not forget your rural communities where successful programming currently exists and the importance of the continuation of funding. Thank you.
Thank you. Next caller.
Chair, there are no additional callers to provide public comment at this time.
Well, thank you so much. Thank you, Administrator Finney, for your presentation on the information today and answering all the questions. Thank you, committee members, and thank you, everybody who joined us for our meeting, as well as those who testified in public comment. With that, this meeting is adjourned. Thank you.